A very good day to all of you, and I'm really grateful to the organizers of the 11th year of Golden Bridge Conference, and particularly Professor Li Jiangming for this very kind invitation. I've been asked to talk about can we avoid the financial and the drug toxicity in the management of oligometastatic renal cell carcinoma. My name is Professor Hammad Ather. I'm Professor of Urology at Aga Khan University in Karachi. We know that renal cell carcinoma can present either as a localized disease where the treatment options are relatively straightforward, which means radical kidney sparing surgery or radical nephrectomy with maybe in adjuvant therapy, the role of which is not very clearly defined. However, if we go to the other end of the spectrum, which is the metastatic cancer, if you have low or intermediate risk, cytoreductive nephrectomy followed by systemic therapy or in the reverse order is the norm, whereas for high risk cancer, systemic therapy is given first, which may or may not be followed by cytoreductive nephrectomy. In the middle of this spectrum, there is another condition called oligometastatic cancer. Now, oligometastatic cancer is neither localized nor metastatic, and it is somewhere in between, and the management also is somewhere in between. The radical local therapy is added to standard systemic therapy in most situations. Now, what is oligometastatic disease? We know that if there are less than 5 metastases on imaging, this is clinically considered as an oligometastatic disease. Either it is induced oligometastatic disease, which means there is a previous history of polymetastatic disease and the metastatic deposits have been reduced by treatment, or it's a genuine oligometastatic disease with no prior history of polymetastatic condition. Now, the genuine could be repeat oligometastatic disease with previous history of oligometastatic disease, or it is de novo oligometastatic disease, which means that the metastasis is identified at that particular time. And these metastases could be either metachronous or synchronous. Another terminology is defined by the EORTC Oligo Care and published by Guckenberger and colleague in the Lancet Oncology a couple of years back. Also defined oligorecurrence as a diagnosed during a treatment-free interval, and oligoprogression as during active systemic therapy. If there is progression of the disease, this is oligoprogression, and oligopersistence is progressing on current imaging. Start off with a case that we recently managed, a 56-year-old male with no prior comorbidities. He has, except that he has a history of lung carcinoid for which he underwent a pneumonectomy in 2015. His routine metastatic screening with the CT demonstrated renal mass last year. Options of treatment was discussed, and it was a localized disease, so he was given an option of radical nephrectomy. It was a 9 centimeter tumor, uneventful surgery, and the histopathology showed a 15 to 20% rhabdoid differentiation, a high-grade cancer, and it was staged as PT2A and not M0. All margins were clear. Now, on follow-up, CT at 3 months was unremarkable, except that there was a suspicious lesion in the renal bed, which the radiologist thought is not malignant, and its post-operative changes. However, at 9 months follow-up, the renal bed lesion increased in size. It was well encapsulated, and there was another well encapsulated mass on the scar site. It was an open radical nephrectomy, as you can see here, and this is the renal bed recurrence. The biopsy of both the lesions showed metastatic renal cell carcinoma. Now, at this point, you have an option of either active surveillance. However, we know that the disease has progressed quite rapidly in 6 months' time. Systemic therapy is an option, and we know that it's very effective. However, there is another option of focal cytoreductive treatment of the primary and the focal metastatic directed therapy, which essentially means that you either use surgery or radiation therapy to achieve take care of the oligometastatic disease. So after tumor board discussion, the patient was advised metastasectomy. The skin lesion, the scar site lesion, was completely removed. It was well encapsulated. However, the renal bag tumor was badly adherent to the muscle. It was a diffuse disease. It was removed piecemeal, and we were suspecting that this patient would have not clear margins, so there's a possibility of recurrence. Now, at this point, systemic treatment was advised, and the patient is undergoing systemic treatment, and he's 3 months down the treatment, and there is a complete resolution of the disease. We know these systemic agents, either the anti-angiogenic agents, have significant side effects. And these side effects sometimes result in discontinuation of treatment as well, including hemorrhage, thromboembolic conditions, hypertension, impaired wound healing, leukoencephalopathy syndrome, which is fortunately reversible, and proteinuria of varying degrees. The immune checkpoint inhibitors, again, creates a condition in various organ systems as if the patient is immunocompromised. And it can result in, for example, in kidney, it can result in interstitial nephritis. Otherwise, it's associated with diarrhea, fatigue, cough, nausea, skin rash, poor appetite, constipation, and muscle and joint pains. Now, another important problem, at least in our part of the world, is the cost and the quality of life. If you look at the international data, we see that cancer-related spending in 2018 in the United States alone was over $150 billion. And the greatest contributors were medical supplies and non-physician services, including the use of the anti-neoplastic drugs. The per cycle cost of Nivo-EP is close to about $21,000. Similarly, the very commonly used combination of exitinib and pembro can cost over $27,000. Now, not only the actual cost, but also the management of these patients can also result in significant cost factors, which can go up to $2,000 to $3,000 per month for management of various complications. These patients, if treated by cytoreductive nephrectomy, the treatment-free intervals can range from around 1 year in about 2/3 of the patient, and the systemic treatment can therefore be delayed or prevented even at times. We know that kidney cancers have traditionally been radioresistant. However, the modern radiation therapy using stereotactic body radiation therapy for management is finding its role now. SBRT in the management of oligometastatic disease can provide local control rates at 12 and 18 months close to about 90%. Randomized trial of 99 patients with metastatic solid tumors show that 1 to 5 metastatic lesions, the palliative SOC versus SOC at 1 SBRT to metastatic deposits, the overall 5-year survival is 42% compared to 17% in the control. Development of new metastatic lesions can again be receive salvage radiation therapy. So these technological advancement, radiation technology, which is often MRI directed, can provide another tool for localized treatment with significantly less side effect. Now, sometimes we make those decisions based upon our understanding and data and how efficacious these treatments are. However, this interesting survey by the KC Cure, Kidney Cancer Cure group, show that people, when asked about what is important in the management of metastatic cancer to them, the chances of eliminating all disease is there, durability, improved quality of life, rapid reduction of the tumor size and amount, again, the ability to go off therapy and maintain response, low risk of toxicity, reduction of tumor symptoms, and low cost. So all these factors are extremely important from the patient's perspective, and this is a cohort of over 1,000 patients who have metastatic cancer. And we know that we no longer live in the single drug era of like sunitinib or pazopanib or sorafenib. We are living in not even the combination treatment era, which is two drugs, TKI-IO or IO-IO combination. In fact, now triple regimes are often recommended because the heterogeneity in renal cell cancer makes it very difficult for one or two drugs to treat the condition completely. Now, why cytoreductive nephrectomy is effective? Well, if you try and understand the mothership phenomena, that if you destroy the mothership, the satellite ship destroys. And cytoreductive nephrectomy very much works in a similar fashion. By decreasing the angiogenic factors released from the primary tumor, there is often resolution of the metastatic things. The second theory is about the metabolic acidosis, which is induced by cytoreductive nephrectomy, and it often results in altered dynamics of tumor host interface, sufficiently reduce and even reverse the rate of invasion. If we look at data, there is clearly data indicating that patients who undergo cytoreductive nephrectomy, even in the era of immune checkpoint inhibitors, have significantly better overall survival than patients who did not have radical nephrectomy. And this is both for the cancer specific and the overall survival. So what should be the treatment strategy? Well, clearly if the disease, which is metastatic or oligometastatic, it is resectable, then attempt to resect or give localized therapy with SBRT, for example. If not, then systemic therapy is the treatment. What systemic therapy? Well, if there is no rapid progression and there is no need for immediate need for response, then IO-IO combination can be used. However, in patients who are not ideal for IO-IO, like immunocompromised patients, immediate need for response is there. IO plus VEGF inhibitors are recommended. Patients who have bone or liver mets with a kidney in place, Nivo and Cabo combination or Pembro along with axitinib is recommended. So in summary, ladies and gentlemen, oligometastatic RCC typically have less than 5 metastases. Cytoreductive nephrectomy and metastasectomy is a valid option. SABR, which is the stereotactic body radiation therapy, is coming up both for primary and for METS. Active surveillance or metastatic directed therapy can actually delay or reduce the systemic therapy, which may improve quality of life. And there are significant advances in systemic therapy in the past decade, which have significantly improved patient survival in this category of patients. So I thank you very much for your attention.